Great. Thanks so much, Indira. Well, good morning, everyone. Really honored to have the opportunity to share with you our work that's been supported by NEST, for which we're grateful, entitled UDI Adoption, a status evaluation in NEST Research Network Collaborator Health Systems. I'm honored to share this work with my colleague, Dr. Wilson, on behalf of our research project team of Drs. Joe Ross, Joe Drozda, Nilay Shah, Jennifer Ridgway, and Lindsay Emanuel. To the next slide, please. So what we'll do here in approximately the next 20 minutes, and then we'll have some time for questions, will be a brief recap of the UDI background, which Indira very nicely covered. We'll discuss a little bit about prior research that has been conducted in examining UDI adoption, and then we'll focus for the remainder of our time here on our current project. We'll describe it, and really excited Dr. Wilson will share some preliminary early results from our work, as well as some next steps which we hope can help to inform the discussion for the rest of the day and afternoon, and then considerations for where we are today in terms of UDI adoption. The next slide, please. So as Indira really nicely covered, as a result of FDA in 2007 and FDASIA in 2012, in 2013, FDA published the final UDI system rule, which mandated manufacturers to assign UDIs to their medical devices, now available for all Class 3 and Class 2 devices, and with the goal of establishing a system for identification of medical devices through distribution and use. There are significant public health benefits to a UDI-enabled system, reducing medical errors, simplification of entry of information into health information technology systems, improving the information for clinical care, helping to manage recalls, and also identifying adverse events that may be related to medical devices. A huge amount of public health benefits, and most importantly, can also ultimately support effective real-world evidence generation in device safety and effectiveness studies, which is a huge interest of all of ours. To the next slide, please. So manufacturers have abided by the rule, and most Class 2 and Class 3 devices, as well as implants, now have the UDI. However, there's no regulation to require that health systems implement the UDI. That is, that they capture the UDI and have it available in their health information technology systems. And therefore, there's concern that this information may not be routinely collected without a requirement, and this could be an impediment to the development of a comprehensive UDI-enabled system for RWE generation and the broader use of UDI. We'll delve into that shortly. Next slide, please. So I wanted to discuss a little bit of preliminary work prior work that's been conducted led by the BUILD PI, Dr. Drozda, as well as Dr. Wilson. This was the BUILD initiative, building UDI into longitudinal data for medical device evaluation. The goal of this effort was to evaluate the experiences of health systems that had implemented UDIs, and the outcome was a roadmap for UDI implementation in health systems. An additional objective of the work was the development of a distributed data network with device data, including UDIs from 3 health systems, and an outcome was the use of real-world data for the comparative analysis of safety and effectiveness of coronary stents. So prior work has been conducted in this area, and on the next slide, I'll tell you about our objective for this project, which was to characterize UDI adoption and use, and really focusing on barriers and facilitators. What has supported UDI adoption and use within health systems, and what's been a barrier, and what's needed to be navigated, and what needs to be navigated in order to facilitate adoption and use across NEST Coordinating Center Research Network Collaborator Health Systems. To the next slide, please. And so here are the project methods. So what we've done is we've developed iteratively and now deployed and completed a brief pre-interview health system survey for health systems that are a part of the NEST Research Network. And in this survey, we asked them sort of basic demographics. How many hospitals in the system how many beds, what's your electronic health record, ERP, enterprise resource planning system, and is the UDI captured, and if so, where? Our goal with the pre-interview survey is to get a landscape view of the UDI within these health systems. We then have been conducting semi-structured interviews by Zoom. Our goal was to conduct in-person visits, but as with many things the past year and a half, we've moved over to Zoom and conducted interviews, and we'll share some of the demographics of those and the results with Dr. Wilson in a couple of minutes. We've focused on targeted participants, which we'll share, in particular the NEST Research Network lead, as well as health system leadership, clinical leaders in various areas, such as interventional radiology or cardiology, the cardiac cath labs, or in the operating room. We've also met with individuals in supply chain leadership, individuals in health information technology within health systems, as well as research leaders conducting medical device related research across these health systems. All of the interviews have been recorded, they've been transcribed as well as de-identified, and we're now in the process of analyzing these transcripts. To the next slide, please. So the domains of our semi-structured interviews have focused in a few areas. First, as I mentioned, we're very interested in UDI implementation. What was the purpose? Why was the UDI implemented if it was? What resources were put forth? What were facilitators and barriers to getting those resources, to implementing the UDI within a given health system? And then for health systems where the UDI is implemented, what's the use? How is the UDI actually being used? Is it being used to help make recall management more efficient? Is it being used in clinical care? Are clinicians able to have access to the UDI? Are patients able to access the UDI for devices that may be used in their clinical care? Are these data, is the UDI being transferred to registries? Is the UDI being used for RWE-based research, for QI projects? Is the UDI being used in supply chain? And if it's being used in all of these settings, what helped to support its use? If it's not being used, then why not? And how could things be better as a result of the UDI? We also received and incorporated feedback on our semi-structured interview guide. And some of you, I suspect on this call, provided comments earlier this year for which we were very grateful and which helped to strengthen our work. And to the next slide, please. So here are the basic demographics of our interviews, and Dr. Wilson will share more of the preliminary content that we have. So in total, we interviewed individuals across 8 health systems, and you can see them listed on the left-hand column there. Children's Hospital of Philadelphia, Duke Health, Mayo Clinic, Mercy Health, New York Presbyterian Weill Cornell, University of Florida Health, Vanderbilt University Medical Center, and Yale New Haven Health. In total, we conducted 33 interviews. You can see the distribution on the right. Some interviews included more than one person. And in these interviews, we really sought to understand the continuum of implementation across these 8 health systems that are part of the NEST Research Network. To the next slide, please. The areas of focus, as I mentioned, for the individuals with whom we met were across the continuum. Research leaders conducting RWE-based research focused on medical device safety and effectiveness, clinical leaders, supply chain leaders, informaticians, as well as administration leadership. And now I'll pass the baton to Dr. Wilson, who will share some of our preliminary findings with you.
Okay, thank you, Sanket, and also thank you to the prior presenters for really providing very wonderful background as we talk about our project. Next slide, please. Okay, and as Sanket brought up, these are really very much preliminary findings. We are moving forward to do a very kind of in-depth analysis of our interview data, but we wanted to share at this meeting some of those kind of high-level findings. So first off, when we think about facilitators, so really coming from the systems that have implemented UDI. So why? What was it that was really those factors that were supporting that? And so here I've listed 5 different factors that I want to talk about. Number one, these systems were able to define a purpose. So they really had a reason why they were implementing UDI, in some cases, reasons, but they had a very clear purpose of why they want to do it and how it would value their health system and the benefit of it, of UDI implementation. Secondly, in these systems, they were able to share data and they were able to really show, kind of project that return on investment and project those improved metrics of UDI implementation. And particularly in the areas of reducing error, reducing time, and improving efficiency, accuracy, and then of course, cost. A third factor in these health systems and in terms of facilitators was leadership buy-in. So they were very much able to get that commitment and support from their high-level leaders within the organization. A fourth factor is they had a champion who was almost always a clinical champion. And this person was very influential in driving UDI implementation in the health system, and really kind of being able to talk to people and float between traditional, excuse me, silos within a health system. And a last factor are relationships. So really the folks in these health systems had significant connections and communications internally. So talking to other stakeholders within their health system and sharing information and building trust and relationships, but also externally with, for example, the US FDA or various industry groups where they were talking to others and building this relationship and also knowledge. Next slide, please. So I also want to share the barriers. And as we talk to health systems, they're really on a continuum, as I would call it. We had some very mature systems with UDI implementation, some that were just going to be starting and been planning quite some time with UDI implementation, and others where it was somewhat fragmented or it hadn't really started yet. So the barriers and the factors that were really contributing were a few. One was the lack of mandate. So that lack of requirement for health systems to implement UDI. So in some cases, that was it. It wasn't going to go any further without the lack of mandate. There was also another factor, the lack of awareness. So really that deep understanding of what is UDI and how will it benefit our system. And in many ways, this was linked to relationships, hearing from others and knowing what other health systems may be doing and the value they were accruing from their UDI implementation. And also relationships internally and talking to others that may have heard about UDI. So kind of a lack of awareness about UDI. And lastly, that inability to develop an economic case. So they really couldn't develop that return on investment for investing the time and the money in UDI implementation. So in many ways, when we talked about the facilitators, certain hospital systems face these barriers. They weren't able to really move forward with developing their purpose and getting the leaders involved and the champions because they were stopped with some earlier barriers. Next slide, please. So I want to share a couple key early insights. One is when we talk about, from the research perspective, real world evidence generation about medical devices, safety and effectiveness, that is not a primary motivator for health systems to implement UDIs. So despite the great interest with a number of researchers in wanting to use UDI in their research, that is not enough to solely drive it. So there's really an urgent need for other strategies to drive UDI adoption at health systems. Next slide, please. And a second early insight was some of the really important information we heard from health systems that had not implemented UDI, did not have UDI adoption. And they really shared some of the challenges faced with their research, real world evidence-based research about medical devices. And you can read these yourself. But I think the bottom line is really bring forth the significant manual level of required with the current process of chart review, how time consuming, it's expensive, it's hard to scale up, and also without having a data standard. And if they could have UDI and a data standard, that ability to do much better rigorous evaluation. So I thought these came out of the mouths of interviewees to really sharing some of the kind of frustrations and challenges. Next slide, please. So where are we going with the project? As mentioned, we are moving now to do a very in-depth data analysis of our interview data with our goals of generating a report to NESTec in 2022, and also to move forward with developing manuscripts for consideration at peer-reviewed journals. And also, we very much out of this study want to kind of build on, as Sanket mentioned, the build project where a roadmap was created, but very much build on this knowledge and steps that health systems need to follow and to know about as they move forward with UDI implementation. And so really augment, a roadmap with more information about how to address barriers and how to really reduce some of the complexity in something that's actually quite complex to pursue. Next slide, please. So as we move forward with the meeting today, here's some, considerations I hope we all really can think about during our discussions. The goals, these kind of ultimate goals of the FDA UDI rule, unfortunately are unrealized. There are currently significant limitations, in health systems with UDI adoption. So really to move forward and advance our real world evidence for device evaluations, we need UDIs to be captured in clinical care, which is going to happen obviously at the health system level. Next slide, please. So here are some areas, again, for consideration as we have our discussions today. Of areas to really talk about and focus on. We certainly heard one of the barriers was lack of a mandate. So policy and incentives has to be an area to talk about where we are and where we need to go and what are other levers that we can help with UDI implementation at health systems. We also heard another barrier, the lack of awareness, and that very much taps into education and how well are we disseminating information, broadening knowledge about UDI, making it a little easier to understand, and even helping provide some standard education materials. So another area that's important for us to talk about today. And we brought up relationships. We also heard earlier really about the wonderful collaborative work that's ongoing, but another area of focus, who else needs to be involved? How can we broaden that and make it almost more inviting or for others to really know about all of these groups? And leadership. We very much need a higher level leader to drive all of these different pieces of this. Lots of really good work is being done and been done, but to really harness this and drive this forward. And lastly, what I'm calling targeted research. Research can very much influence practice and policy. So I hope that we get some ideas out of this meeting. What are some of those areas that we need to do in research to do such? Next slide, please. And then last but not least, I'm very happy to say that there is now a UDI Center, UDI Adoption Information presence on the NESTec website. It just went live yesterday. These are the 7 areas that are included in the web pages. It's really designed for many audiences, folks that may not know a lot about UDI. There's basic information, not that complex. What is UDI, but also provides links where folks can go and get more information about what is a UDI, what is the good ID, what it is, and also links to the Access Good ID. We talk about the benefits of UDI from a clinical, patient, post-market safety, surveillance, research, and operational level. Also gets into national policy and initiatives and has a timeline of the various steps and things that have happened along the way. Presence for our project, and we'll be posting deliverables as they become available. And it also includes some clinical registries where UDI is included and accepted in their data sets, and some research projects that have had UDIs in their data sets. And lastly, quite a robust section on publications. You may not be aware that the evidence base has really been growing for UDI. And so there's a number of publications. So you know what's out there, what's been published in peer-reviewed journals and various reports. And here is the link for the direct link for the website. And so I hope that you'll go on this, but also share it with colleagues and send it out, because I think it's a really good resource for people to learn about UDI. Next slide, please. Okay, well, thank you. And we would like to just open up if there are questions.
I think we have one question that we'd received about the approximate percent that a lack of a mandate as opposed to other barriers might be in not supporting implementation. That is, if there was a mandate, how much would that help to support implementation? And it's hard to quantify. We haven't sort of quantified the exact barriers, so it's sort of hard to know if this is 100% or not. I will say it's really the combination of a bunch of barriers and the combination of a bunch of facilitators that to date have helped to support implementation. Certainly, we have heard, as Natalia mentioned, that the lack of a mandate, that if there was a mandate, that health systems would push forward. And particularly one mandate that might be is if it was necessary for billing, for example. That is, if you used a medical device within your health system and in order to bill for it or for its implantation or use, you needed to transmit the UDI, then certainly that would be essentially a necessity for health systems. So I think there's a little bit of a continuum in terms of what a mandate would look like and what it would look like to truly be a requirement, a bit less, but definitely a combination at this point in time in the absence of a mandate of a variety of barriers. Natalia, do you want to comment on that at all?
I will. The one thing I want to say is when I'm thinking about an analogous mandate, I'm thinking about the UDI system rule. I mean, that was a mandate that was very clear. This is what needs to be done. This is the timeline. There was some teeth in it. And honestly, I haven't seen anything, equivalent to that that's come out. And so that's how I think of kind of what is lacking in terms of a mandate. And in terms of the percentage, of a mandate versus other barriers, it's really, it's somewhat hard to answer that question, and I'll tell you why. When we did the build project, we talked to people who had already decided without a mandate they were going to implement UDI. So they had other barriers they were working through with IT interoperability, some of the kind of just basic human resource barriers and all of that. And in this project, we certainly have more of a continuum of folks, but we don't really have a very large N. So any comment on that would have to be sort of kind of, I guess, personal opinion. I think the lack of mandate is pretty significant, to be honest with you. But I really can't give you a percentage. I don't think it's been studied. I'm looking at the question from Nancy. Thanks for asking that about the 21st Century Cures Act, because Sanket and I have been talking about this, and I know we both have looked at the act because we have also heard that that was a driver for at least one of the health systems that we talked to. But we found it very murky to find where exactly it said in black and white that you have to include UDI. So Sanket, I don't know if you want to make a further comment on that.
Yeah, that's right. Several members of our research team have spent actually several hours pouring through the Cures Act, and there's nothing saying that health systems must include the UDI and the electronic health record systems. As Indira nicely shared, it is a requirement that the UDI, that electronic health records that are certified as part of meaningful use have the ability to capture the UDI. But we're finding, as we shared, is that a lot of times the UDI, that field, even though it's available, is blank. So certainly, if there was a mandate, that would be really helpful. And just sort of on the topic of mandate, a great question from Indira. Would CMS adopting the latest X12 standard with the UDI DI serve as a sort of a mandate? That is the latest that the device identifier must be in claims. And I think absolutely 110%, that would be an important mandate if that had come through. And there's been interest from multiple levels. I know, Natalia, you've been on the pulse of this, and maybe if you want to say a word about the UDI and claims and even the demonstration project showing that this can be done.
Yeah, absolutely. First of all, I agree with you fully that if CMS came out fully in support, we're going to do this, that would just be huge. And in fact, the UDI to claims project, which is really a proof of concept to show that the UDI can be captured, the DI can be transmitted from a health system to a payer, was done and was published. We also wrote a health affairs blog. It was on April 23rd that really got exactly at this point, that really if CMS came out and this was a requirement, that would move volumes. And that was actually out of our interviews of national stakeholders, that was really a recommendation.
We also have a question about if the UDI is a field in Form 3500 for entering data into MAUDE. And my understanding is that it is, just as the NDC or the National Drug Code is for pharmaceuticals. And so certainly, and as Indira mentioned, is sometimes being included and increasingly often being included as well. And then we have a question about any comment on interoperability standards for UDI, for example, point of care, medical device, tracking integration profile using FHIR? This is a tricky question. Natalia, do you want to comment on it?
Yeah, unfortunately, it's not an area I'm well versed in, so I'm very sorry I cannot comment on that.
The same with me. My understanding is that certainly interoperability is a major issue. But this is a standard as Indira mentioned, sort of separately. The issue of different labelers and is one that we learned, at least sort of indirectly, is one that can sometimes be tricky. But this might be one question that we can have answered perhaps in the next session as well. Great questions. Thanks so much. I see one question is, in the absence of a mandate, have you looked at the patient's willingness to capture their own UDI information? And if so, how would they be able to advocate for that self-UDI capture? Natalia, do you want to take this one?
Yeah, I would love to take this one. Actually, as part of the UDI to claims project, we did focus groups of patients who had implants. I think this is one of my favorite projects within my UDI work, and to really understand their knowledge. Did they know about UDI? And they did not. I mean, this is a huge area for advocacy. And what was really interesting is two patients in the course of the focus groups found out they had UDIs on their implant cards, had no idea about them. And so absolutely, this is something, I mean, patients should be asking for, but I frankly feel that every patient should be getting an implant card with the UDI. And that was a recommendation that actually came out of our publication. And so I think this is a huge area to focus on and work on, because right now, some patients don't even get implant cards at all, with or without UDIs. But yes, I think if, patients ask, but a lot of physicians kind of are wondering, why are you asking me this? Because there's a lack of knowledge with a lot of physicians in this space.
Thanks, Natalia. And I would just add the importance of patients also being able to share with their clinical care team in the future. If they need a revision surgery, if they have a specific type of device, and obviously Good ID has a lot of important factors. And for clinicians this could directly inform clinical care if it's available to patients, especially given that patients might or oftentimes use different health systems. And so they may have received the implant 5 years ago in health system X, and now they're receiving care in health system Y.
Yeah, and one other thing I want to say was interesting during the focus group, patients very quickly caught on, wow, I might be moving to California. Or actually, my physician, he just closed his office. I never saw him again. So they realized the incredible value long-term for themselves, that they had that information.
We have just a couple minutes left. We have a question about the fact that there are multiple UDI DIs that are required to comprise a fully implantable device in many instances. And absolutely, for example, orthopedic hip implants or a pacemaker that includes a generator and multiple leads. Is it feasible to capture the UDIs on claims? Natalia, do you want to take that one?
Sorry, I'm not seeing it here. Is it feasible to capture the UDI in claims? That was, yeah, I mean, in the UDI to claims project, and I'd be happy to share those publications. They're actually on the website that's up there. It's divided in publications, and you'll see for claims all of the publications there. But absolutely, I mean, it was a proof of concept that absolutely they were able to do this. The difference is we're moving to an updated claims form. So for the project, it had to be put in kind of a free field. But absolutely, we were able to do it.
This is great. We probably have time for one last question, which is during the FDA's Patient Engagement Advisory Committee meeting, I think a few weeks ago, that was focused on recalls. Implant cards came up quite a bit, and patients may not know what those are, how to use them, and many may not, as Natalia mentioned, even get them. And have we conducted research to see if there's a standard format for implant cards? I'll just say this has not been a part of our project, but I can tell you certainly from clinical experience and sort of what we've seen that there is not a standard. Natalia, do you want to speak to this a bit as well?
Yeah, there is not a standard, and frankly, there needs to be a standard. The one registry that's been capturing at the point of care UDIs, a National Breast Implant Registry, and they have like incredible patient information and physician information, and really kind of are moving towards that standard. So I think they're actually a good model. That's not to say other registries, they're also capturing UDI, but because of the increased incidence of large cell anaplastic lymphoma with the breast implants, they moved to capturing the UDIs. So another area potentially for research.
More work to be done, absolutely. Well, on behalf of our entire research team and Dr. Wilson, thank you so much for the opportunity to share our work. We are really delighted to conduct it and looking forward to rolling up our sleeves and getting some more final analyses and sharing these with all of you in the community. Please do check out our website as well, as Natalia shared, and really so delighted to have that as a part of the NEST website. And next, we'll be handing over to Terry Reed, who will be moderating the next session on breaking barriers to device identification. Take it away, Terry.